So, good morning, everyone. I first wanted to welcome, we have a number of cardiology fellows who are interviewing here in Montefiore today. So, welcome to Monty. Good luck with your interviews. I hope today's conference gives you some taste of the kind of academic activities we offer at Monty and will hopefully excite many of you to want to join us. But because we also have like one of the best speakers ever. We have Rasha Lamy, who is really, I guess, in the last few years, has really become one of the most well-known researchers in interventional cardiology. Me and Rasha got to work together. I was lucky enough to be, close to her, and I'm under her shadow, I think. Um, as she's done a series of randomized studies that I think forced every single one of us who does interventional cardiology to pause, to think about what we do, and to think about whether what we do has benefits for patients. And certainly with the first study she did, I know she received a lot of resistance from mentors, criticism, but you stuck it out, Rasha, and I think you've now created like a whole legacy of orbiter studies that all of us are all just waiting to see which other preconceived notion are you going to force us to challenge and make us better, because maybe some of what we do is not really based on science. So it's always a pleasure to talk to you. I miss you like crazy, and I hope one day we'll be able to work more closely together, maybe even in the same city. Who knows?
Yeah, thank you, Izzy. What intro. So I guess the to back up your intro, I think I need all of your new fellows and your current fellows and the people who are prospective fellows to understand that lots of what I know about PCI, Azim taught me, and lots of what I know about research actually came from a year in Milan with Azim, where I was exposed for the first time really to thinking about clinical trials, how our clinical data might impact on what we do, and kind of we worked in an era where we were being challenged every day, and you taught me a lot of what I know. So thank you for having me back. Some of what I will speak to today is stuff that I've spoken to your team about before, but obviously, hopefully, some of it will be new data. So I'll crack on with the presentation, but fundamentally, please feel free, any of you, to ask any questions at any stage. So here are my disclosures. So the space that I've really covered within my research has been a space that I guess for decades has had most of us thinking we knew all the answers. There's been perhaps some dogma around what we were taught, and it was partly out of the need to ask more questions, but also because I've always felt that it's reasonable to question what we do and think about whether what we have considered to be absolutely standard practice could be revisited in a modern era. So that space is stable coronary artery disease, and it's coronary arteries like this. So it's patients who come into us in clinic telling us that they have exertional symptoms or equivalent symptoms, who then come into our cath labs and we find narrowings like this. And the question in the space of stable coronary artery disease has been, how should we approach it? What should we do? Now, for a long time, I think we believed that we could do all sorts of things in terms of reducing the frequency of patients having myocardial infarction, perhaps improving their life expectancy and reducing the risk of cardiovascular death, maybe in those patients with heart failure, improving their cardiovascular or their LV function. But fundamentally, all of the trials that have looked at these aspects of revascularization within stable coronary artery disease have come to the same place, which is that actually the data is quite poor. And where we're left now is with revascularization and particular PCI, but actually revascularization overall being fundamentally done to improve symptoms and quality of life in these patients. Now, I don't think that's a bad place to be for interventional cardiologists. We've hoped that we can save lives in stable disease, just like we do in acute coronary syndromes. But in fact, if in stable disease, the main remit of what we do is much like an orthopedic surgeon with a total knee replacement, that's okay. Symptoms and quality of life are really important to our patients. And importantly, angina is a real burden to live with. And our patients come to us in clinic saying all sorts of things about how their angina is affecting them. They can't work as much as they would like to, they can't exercise, and they put on weight. They worry about the impact of this condition on potentially causing a heart attack or causing them to suddenly die in the future. And this is really important to them. Importantly, as they have angina, it takes a serious toll on their quality of life. And many, many patients will say that their angina episodes have a significant impact on what they can do, and that often some of those episodes of angina will be very, very debilitating. They can't play with their children, they can't do sport, they have lots of worries about their future health, and it affects their relationships and it affects their jobs. And actually, improving angina is really important to our patients. So there's also complexity around angina, and this comes to kind of where we are in the 21st century, in that we're starting to recognize that how and when we assess angina impacts a lot on what information we glean. So we the physicians, and of course the patients, will have multiple time points at which we assess angina, or they tell about their angina in the primary care physician at the outpatients clinic, perhaps at their various investigations, or as we follow them up within our various outpatient clinics. And importantly, we do this all the time within our clinical trials. Now, the issues around all of this is that actually the assessment of angina is really complicated. There are patient-reported factors, so they may have language issues, they may have issues in terms of understanding questions, depending on what time we give them to give their answers. And obviously, as we repeatedly question a patient, they may change what they say. But importantly, if they have preconceived beliefs of what we have, what we have done might affect their angina, they might tell us something different. And similar factors really resonate around the physicians too. What I say is CCS2, someone else might say CCS3. If I believe my stent worked absolutely perfectly, I might say that a patient's got atypical pain when they tell me they still have symptoms. But if I think that there's residual disease that I could treat, I might say this is cardiac chest pain and it's time to get them back into a cath lab. And the reason this is all important is because angina is a subjective endpoint. It sits with quality of life and breathlessness and other subjective endpoints. Different patients will report it differently on different days. And importantly, even the same patient will talk to angina in a different way depending on what else is going on in their life. So now let's think about why that's important in terms of clinical trials. Well, the issue with the subjective clinical endpoint is that it can be influenced by various factors. So if we think about any therapy, a medical therapy or even an interventional therapy, and we hope that obviously it will improve our patient's angina or quality of life or whatever that might be, a subjective clinical endpoint. And we can say that that improvement is this blue box. What we know for a subjective endpoint is part of that improvement will be the placebo component, and part of it will be a true physical biological effect. Now, of course, as physicians, what we want to do is increase the size of that blue box. And we might do that in two ways. One might be to increase the physical component, the placebo effect, by improving physician-patient interaction, by reassuring the patient, by telling them the problem's fixed. And of course, we do that all the time in our unblinded clinical trials and in our unblinded clinical practice. But we might believe increasing the placebo effect will only last for a certain period of time. So it might be better to increase the size of the blue box by increasing the physical effect. And to do this, we might choose therapies that have the best effect, maybe select the right patients, the ones that will benefit the most. So why does it matter? Well, it matters in terms of how we design our clinical trials, but it also matters depending on the endpoints we choose. Now, we might believe that something like an exercise-related endpoint is very objective. It takes away some of that subjectivity in terms of angina reporting. But actually, what we've learned is that the endpoint you choose can be very much influenced by things like the placebo component. And for an exercise-related endpoint, which feels objective, in fact, the impact of placebo is far more than you might imagine. What happens is if you tell a patient you fixed a problem and you have an unblinded clinical trial, you put a patient on a treadmill, they will go a bit further because they know you fixed the problem. And you will push them a bit further because you know you've fixed their problem. And then you have a double impact on that exercise related endpoint. And in fact, interestingly, there are some endpoints, and here you can see recurrent bleeding, that are really quite resistant to unblinding. because it's hard to fake a big major bleed, or not so much to fake it, but to influence the recording of that endpoint. So we've tried to quantify the physical effect of PCI. Now, I say specifically physical effect because in a blinded trial, it's actually very hard to quantify the true placebo component because, of course, within a blinded trial, you can't lie to a patient. You have to tell them it's 50-50. You might be randomized today to either have placebo or the true treatment. And so, therefore, what we do in our blinded trials is quantify the physical effect of a particular therapy. And I'll talk to PCI first. So in our first of these trials, the Orbiter trial, we took patients with single vessel coronary artery disease, stable angina, and we wanted to see if PCI worked on a background of guideline-directed anti-anginal therapy. And to Azim's point, the results were quite shocking. They showed that PCI didn't work quite as much as we expected on that exercise time-related endpoint. Importantly, we quantified the size of that green box, the physical effect, and it was much smaller than we expected, and in fact, much smaller than we'd seen from previous unblinded data. Now, of course, that led lots of people to be quite shocked, but we looked at that data much more closely. We found that it wasn't a case that PCI didn't work at all. Yes, it didn't improve exercise time like we expected, but it did improve ischemia. The blood supply to the heart was significantly better in people who had PCI versus a placebo procedure. Importantly, we looked for predictors. Who were the patients who were most likely to benefit from their PCI procedure? And we found that most of our baseline markers of ischemia, and in this case, invasive physiology, could not help us to predict those patients who benefited from PCI. There was only one marker that we could use, and that was stress echo score. So if a patient had very high level of ischemia seen on a stress echo score, they were much more likely to improve with PCI versus a placebo procedure. Now that led us to think about stable coronary artery disease as an overall. And we started to realize that the link between symptoms, the narrowing that we see on the angiogram, the stenosis, and ischemia are actually not as closely linked as we might think. And it made us think about what's next and how we could test this further. And in thinking about the testing of it, we started to design Orbiter 2. Now, bear in mind that Orbiter 1 was the first placebo-controlled trial in this space, but it was done on the basis of the guidelines at the time. And what was very important to us was to test the effect of PCI on guideline-directed anti-anginal therapy, because we were worried that if we didn't do that, many people would criticize how we designed the trial. Now, with the results of Orbiter 1, what we realized was that actually the very high intensive medical therapy that we had in Orbiter 1, where patients were on an average of 3 anti-anginal agents, was not really real world practice. In fact, in the real world, most patients are on 0 or 1 anti-anginal at the time at which they have their PCI. So the question was, could we actually test this again, do another placebo-controlled trial, but in a real-world population? So in Orbiter 2, we were able to make various changes. We increased the population of patients from single vessel disease only to single and multi-vessel disease. We mandated that patients had to have evidence of ischemia before randomization. And importantly, we chose a new endpoint, an endpoint that was much more patient-centered, the angina symptom score, which I'll come to tell you about. We also increased the duration of follow-up out to 12 weeks, although I'm not sure that that made an impact on the trial, but that was easier to do because we were changing some of the design of the trial at that time. And importantly, we took patients off their anti-anginal therapy. And that allowed us to ask a primary question, which was akin to what had been modelled in the renal denervation space. We asked whether PCI without anti-anginal medication could improve angina compared to placebo. So essentially, what was the unattenuated effect of angioplasty? Now, importantly, in the past, the way in which we really looked at angina within clinical trials has used varying questionnaires, and you can see the different questionnaires that are available to us. Now, those questionnaires have been very important, but they have a series of limitations. There are issues in terms of recall bias and what one patient can remember and another patient can't. There are issues in terms of response, and maybe someone who's more symptomatic responds more than people who aren't. And importantly, there's behavioural change. patients may change what they do in order to stop their symptoms. So if I get pain every time I play tennis, I stop playing tennis so much. And importantly, all of these questionnaires were validated against a daily angina diary. And that's where it came to us thinking about how we could do things differently. We also had realized that actually patient recall is really inaccurate after 3 days. Essentially, if we think of our own lives, it's actually quite hard to remember what happened a week ago. And what we realized is that recall is best within about 3 days of the episode of the symptoms of angina. So we developed a digital tool for assessment of angina. And this was based on a daily angina diary, but essentially what we were doing now was collecting it using a smartphone application. And this was actually developed with our patients, allowing our patients to help us to make a smartphone app that would allow daily reporting of symptoms. And this is what we developed, the Orbiter app. It basically asked the patient, did you have angina yesterday? And they answered yes or no. If no, it capped out. If yes, how many times did you have angina and how bad was the worst episode? This was the design of the trial. Patients were enrolled and had their symptom questionnaires. They had their anti-angina medication stopped, and then every day they're reporting their symptoms on this smartphone app. Only if symptomatic did they progress throughout the trial. They came in for a pre-randomization visit with questionnaires repeated and a series of tests for ischemia. And then they came in for the randomization visit, which was very similar to Orbiter 1. They were listening to headphones with auditory isolation. They had a standard angiogram and physiological assessment, and then they were sedated to a deep level of conscious sedation before being randomized to PCI or placebo. If they'd had their anti-angina medication started, it stopped again. And then importantly, they then went into a blinded follow-up phase where they and their medical caregivers had no idea what they'd had done in the cath lab. And every single day they were reporting their angina on the smartphone app. And finally, they came in for a follow-up visit where they had some of their baseline tests repeated. And then they were unblinded and returned to routine care. So importantly, the primary endpoint encompassed a few things that the patient said were really important to them. The number of episodes of angina, the number of anti-anginal units, and also some high ride category events. And that made a daily angina symptom score. Now, this was an ordinal score, so that every day for the trial, they were given a different level on this score. It went up as they had increasing episodes of angina, went up as they had more anti-anginal medication, and then it was higher still when they had one of those high ride category events. So if on a particular day a patient had 2 episodes of angina but were taking no anti-anginal agents, they scored 2. If later on in the trial they were taking 3 units of anti-anginal medication but only had 1 episode of angina, they scored 22. And if at any point they had an ACS, they scored 78, and that capped out their score throughout the trial. So what did we find? Well, we found that PCI significantly improved the chances of patients being free from angina and free from anti-anginal agents. It reduced the frequency of angina, and importantly, there was no difference in terms of anti-anginal units or those serious adverse events. What we were able to do now was quantify that physical effect of PCI. And you can see the proportion of patients who were free from angina, and importantly, that proportion in the PCI group was predominantly due to a true physical effect. There was still some placebo component, but the physical effect outweighed this. We also saw this on exercise time. So unlike in Orbiter 1, where we didn't see a difference, here we saw a big blue box for the PCI group, and it was predominantly due to a physical effect. Now, importantly, it wasn't a fix-all. It was about an increase of 60 seconds on exercise time, which is akin to one anti-anginal agent. Now, you might say, well, how come it didn't work for everyone? And this was something that was really important. What we found in both Orbiter 1 and Orbiter 2 was that residual symptoms were really common after PCI. And in fact, we see this in clinical practice. So we've gone on to ask, well, why is that the case? It comes back to that link between symptoms, stenosis, and ischemia, and the fact that that link is really complex. So we've started to think about what angina means. And indeed, if you think about angina, we often think about it as that classic condition where someone is seized by pain when they're walking, strangling anxiety, and it goes the moment they stand still. The problem is that we have those symptoms, and then when we bring a patient into clinic and then we take them to the cath lab, we see this stenosis and we forget all of those symptoms. We suddenly start to see that stenosis through those symptoms through the lens of the stenosis. A sickening pain, an aching pain, heavy pain, a spreading pain, they're all the same. They are all related to that stenosis, and maybe that's a major problem of what we do. So we've recently done an experiment where we actually tried within a cath lab to see whether balloon occlusion versus placebo inflation had a difference in terms of their prediction of the response to PCI. And indeed, when we inflated a balloon and created an ischemic stimulus, and if that patient told us that that was very similar to the pain that they got at home, therefore meaning that they had a very high similarity score, we found that that predicted the response to PCI. And in fact, it was a very high predictor of response. So if the pain in the lab was reproduced by an ischemic stimulus and that pain was similar to what they had in their normal everyday life, PCI worked. Now, you might say, well, that's tricky because in order to repeat that experiment, you have to inflate a balloon in a cath lab, and that's certainly true. So what we came on to do was think about how the data we'd collected in Orbiter 2 could help us to predict response. And we asked two questions. Is there a relationship between symptoms and disease severity? And also, can the symptoms themselves predict the response to PCI? Now, in Orbiter, we had collected symptom and disease severity data in a variety of ways. But one of the important things we collected was the characteristics of symptoms. And importantly, we'd use the questionnaire called the Rose Angina questionnaire to try and characterize whether patients had essentially typical cardiac angina. This was pain that was in the center of the chest that was induced by walking or an exertional stimulus that resulted in the patient stopping or slowing down and that subsided once they did this. And interestingly, this seemed to have some importance in what happened next. Now, in terms of the relationship between symptoms and disease severity, we were quite surprised to find that there was no relationship. The worse your disease, that didn't seem to have any kind of association with the symptoms that you had. And initially, I was quite surprised about this. But actually, if you think about clinical practice, we often see patients who have left main disease or very severe three vessel disease, and they're asymptomatic. And then we have patients with moderate circumflex lesions, and they feel debilitated by their pain. So maybe this relationship is true, and actually it holds up in clinical practice. What we did, however, find was that on that Rose angina criteria, if patients had very typical angina, their PCI response was marked and very much different to the placebo response. In fact, you could see that the more typical their angina, the more likely they were to be angina-free once they had PCI. However, if they had really atypical symptoms, the PCI was really not much better than a placebo procedure. So even though they had a tight stenosis, the atypical symptoms did not get better with PCI. And interestingly, there were certain symptoms that really seemed to predict the efficacy of PCI more than others. So a heavy chest pain was much more likely to produce response rather than a shooting pain or a shortness of breath. And this is something we probably need to think about when we're in clinic. Interestingly, the ESC guidelines now really do put symptoms at the forefront of what you might consider to be the diagnosis of chronic coronary syndrome or stable angina, and also perhaps over time, how we might select patients for treatment. And this is a kind of new departure from what they were doing in the past. So now we have two pathways. A pathway where we take a patient with stable angina, give them anti-anginal medication. If they still have symptoms, we might consider PCI. And then an Orbiter 2 pathway where we might select patients with PCI a bit much more quickly, and perhaps even upfront. Now, you might say, well, how am I going to choose between the two pathways? Well, at the moment, we might use lots of patient factors, but also you could use symptoms. If they have very, very typical symptoms, you might use this as a predictor of PCI response. And those patients might get filtered to the cath lab a lot earlier. We're now looking at actually the patient's videos, and each patient in Orbiter 2 was recorded telling us about their symptoms. And we're going to see if even that can be used to predict response, which is so much closer to what you do in clinic. And at TCT, we're going to be looking at and presenting whether other factors like invasive physiology can be used as a predictor of PCI response based on the data from Orbiter 2. Now there's another space that I'd like to kind of talk to, and that's that space of refractory angina. So this is a smaller space, probably affects around 30,000 new cases in Europe every year, although that's potentially really underreporting the size of the problem. These are patients who have both obstructive and microvascular disease, but fundamentally have pain that is refractory to any further treatment. Now, the problem is the definition is really heterogeneous. And actually, what constitutes no further treatment options is really different in different labs. Some people are happy to do 3-vessel CTO procedures, and other people think that that's the point at which there's nothing more to offer to a patient. And so that definition can be different in different clinical practice, but also in the clinical trials. Now, for this space, we have a new treatment modality, and that's something called the coronary sinus reducer. And that's an hourglass-shaped device that sits in the coronary sinus and is hypothesized to redistribute flow within the myocardium, and importantly, potentially improve perfusion within the myocardium. Now, there have been lots of clinical studies in this space. Unfortunately, most of them were observational. And this was the kind of real issue and why I came to want to study this. Lots of people told us that this device worked, but they mainly told us it in open label registries. There was one placebo-controlled trial, and that placebo-controlled trial told us that the reducer improved CCS class in patients with refractory angina versus those patients who had a placebo procedure. Now, interestingly, if you look at the data from this trial, you can see that they quantified the size of that blue box. Actually, the placebo component was far bigger than we might have expected. And interestingly, over time, I started to think about the design of that trial and why that might be. So one of the things that was interesting was that if you look back at the ways in which they blinded the various arms in this trial, there was aspects to it that I was questioning. So one aspect was that they randomized patients to either have placebo or PCI prior to going into the cath lab. Now that's always an issue because you can imagine what it's like in a cath lab when you know that someone's been randomized to the procedure versus someone who's been randomized to the placebo. If they're in the placebo arm, you might put them at the end of the case. You're quite happy for a fellow to come in who doesn't really have experience with the device. If they're for the true device, you might have the full team and the full gambit of everything in the lab in order to do it. They also only treated the treatment group with heparin. So, of course, again, when you come out of the lab, the nurses know that this group got heparin and that group didn't, and that may potentially unblind them. And interestingly, they offered participants either headphones or music, playing music, or conscious sedation. And again, you might think that one or the other might be different in terms of offering true blinding. They asked the physicians to behave similarly for both arms after randomization. So that's also kind of interesting because as those of you who might put in the reducer know, sometimes it's really quick and easy. Sometimes it can take hours as you're trying to access that coronary sinus. So how is it possible that physicians can behave similarly for both arms? And importantly, they never told us about the fidelity of blinding. They never reported how good the blinding was in those trials. And it made me start to think about whether this trial was truly as blinded as it was meant to be. And that was particularly true because in all of the observational data, they told us that actually the effect was very, very similar to that in the blinded trial, which is not very usual because usually in blinded trials, we see effect sizes that are far smaller than in unblinded effect sizes. And importantly, in all of that observational data, what they'd done was give us an effect size, but because they had no control arm, we didn't even know the size of that blue box, never mind the component that was physical or placebo. So I believed that it was impossible to quantify the true effect of this device in single arm studies, and that if the unblinded effect size was similar to the blinded effect size, it really raised questions about the fidelity of blinding. So we wanted to do another trial. Now, importantly, in the US, there is another trial ongoing as well, the COSIRA-II trial, which is a blinded trial looking at the effect of this device on refractory angina. In our trial, in Orbital Cosmic, we asked two questions. What's the placebo-controlled impact of the reducer on myocardial ischemia? How does it work? And also, what's the impact of angina? Now, we took those patients with refractory disease. They had to have angina on maximally tolerated anti-angina medication, and they had to have no further options for PCI or CABG and have the presence of significant myocardial ischemia. We had a trial design that was really very similar to Orbital 1 and Orbital 2 and was fundamentally a placebo-controlled blinded trial design with symptom assessment on that angina app throughout the trial. Now, the endpoints that were important were stress perfusion CMR to look at ischemia, and this was a quantitative sequence using the Kalman sequencing. And the primary endpoints were stress myocardial blood flow, which was the main imaging endpoint, and then obviously the symptom endpoint, which was daily angina episodes on the Orbiter app. There were a series of secondary endpoints, which you can see here, but let's look at our endpoints, our outcomes. So we found no difference on that primary imaging outcome. It didn't seem that the reducer changed stress myocardial blood flow. However, on the symptom, the chances that patients would have less angina episodes. And so it did seem to work compared to placebo. It also reduced angina frequency on the Seattle Angina Questionnaire. It improved quality of life on the McNew Heart Disease Quality of Life Questionnaire, but it had no impact on treadmill exercise time. Now, many people obviously started to think about, well, how does it work? And interestingly, we did find some potential possibility of how it worked on one of our secondary endpoints. We found that in patients with, in their ischemic segments, there was potentially a redistribution of flow. And that flow went from the epicardium to the endocardium, potentially improving the redistributing myocardial blood flow. So, what have we found? Well, we found a number of things. We've found that angina is very complex and hard to evaluate, but our angina app really did allow us to look at temporal resolution in terms of change, and it gave us a sensitivity that perhaps we hadn't had with previous questionnaires. With PCI, we saw that the power of daily data was really there in terms of showing us that PCI worked within 1 day of having the procedure and that treatment effect persisted over time. With the reducer, we also found that daily endpoint and the collecting of longitudinal data was really important. And we were able to see that the device worked at about 10 weeks, which is about the time at which the device is meant to endothelialize. So what's next from us? Well, you're going to hear about other secondary endpoints that are coming from Orbiter Cosmic and Orbiter 2, but also we have two ongoing trials, Orbiter Fire, where we're looking at whether we can detect the point at which you might get angina using invasive physiology and a cath lab protocol that you can see here using a cath lab like and graded in balloon inflation within a coronary artery to see whether we can predict the point at which patients have angina. And in the Orbiter Moon study, we're looking at whether different vessels and stenoses in different vessels might contribute to angina in a different way. And maybe if you get a patient with multivessel disease, you don't have to, you could be given an algorithm that allows you to select the right vessel to treat. Maybe they don't all contribute to the angina, maybe one contributes more than others, and maybe there are certain factors that allow you to predict this. So finally, I'll wrap up by saying the contemporary management of angina has changed, I think. We've realised that angina is an incredibly important endpoint within stable coronary artery disease, but that it's complex and subjective in its assessment. We've got some diagnostic tools, but they have limitations, and that actually residual symptoms are still common after revascularization. We need to get to a point where we can predict the effect of what we do up front before we do it. And with PCI particularly, we now know that there are some symptom characteristics that can predict the response of our PCI and allow us to triage patients to perhaps have PCI earlier in their treatment algorithm. And importantly, there are some new treatment options, and particularly the reducer, that are emerging. And definitely there's more data on the way. And I'll end with a photo of lots of people in my team who've helped us to collect and conduct all of these clinical trials along the way. So thanks very much for allowing me to speak today, and I'm happy to take some questions.
Hi, Rasha. As usual, that was phenomenal. It was really a great talk. I'm going to let some of our fellows and faculty also ask some questions. I had clearly a couple that I want to start with, maybe. So let's start with just the treatment of angina with PCI. And in Orbiter 1 and 2, which again, well conducted, I think have given us a better understanding of what PCI does in stable angina. I mean, in the patients who continue to have chest pain despite having PCI, what do you think the role of microvascular dysfunction is in those patients?
Yeah, so that's actually a real part of what we're doing now in some of our follow-on studies. I think some of those patients will have a contribution of microvascular disease, for sure. Do I think it's the tip of an iceberg that everyone speaks to? Actually, I don't. I think if the size of the problem was truly as much as people say, I
Mhm.
mean, we'd all know patients walking, people around us, friends and family who'd be telling us about their ongoing chest pain and their symptoms. I think it exists for some. I think for others, unfortunately, their stable lesion that we see in a cath lab is probably bystander disease, and some of their symptoms may be nothing to do with their heart, right? And
Yeah,
it's gastritis or whatever else it might
right,
be. What I do think is going to be important is to work out what the size of that microvascular disease problem is, and that's quite difficult in the epicardial space because all of the tests that we have conflate the epicardial and microvascular assessment, and they're very inaccurate in terms of telling us the contribution of just the microvascular component.
right,
And so it takes treatment with the PCI, creating an unobstructed coronary artery space to be able to make some of those tests accurate.
right.
So we're doing some more tests in that, but I don't think the size of the problem is as big as some might say.
Okay. Do you guys have an ANOCA program at your institution?
Yeah, so what we've been trying to do is be more systematic about it. And
Yeah.
then the last few months, we've been systematically assessing patients with unobstructed coronary arteries. And that data for us has been very different to some of the data that I've seen presented from different centres.
Yeah.
I don't know if that reflects our local population, but I'll tell you that that's a kind of general population of patients who are walking around. We don't have a
Mhm.
quaternary specialist angina clinic, but we have lots and lots of patients with symptoms. And we've been assessing them in the lab, and we haven't found quite the burden that others might say.
Okay, great. I'll hold my other question on reducer for a little while. Let's just pass it on to the rest of the team. Andrea?
Yes, first of all, I wanted to thank you again for this brilliant talk. What you accomplished with Orbita is really unique. My question is mostly for young researchers. If you can give us some suggestions from how to go from the idea to the design of such a great trial like Orbita.
I mean, I don't. I've made lots of mistakes along the way, so I don't think I can give you a perfect answer. What I would say to young researchers, and I'm sure Azim can come to this because he's worked with so many people in terms of building their research portfolio, is, I mean, you can't run into a clinical trial before you've started to understand research methodology. You also need to come at it from a place of kind of some humility because clinical trials are really, really hard to do and clinical research is really, really hard to do. And it's so easy to criticize what others have done before. And then you do it yourself and you realize that you know, some
Mm.
things are inevitably always going to happen. But what I would say to the junior people in faculty is it it has enhanced my clinical practice to do research. And the conduct of clinical trials, or even just looking at registry data and understanding research methodology, has totally changed how I practice as a doctor. So it's worth doing it, even if you don't want to become an academic, if you just want to have a more interesting clinical career and to ask some good questions, basically.
That's a great summary. especially the last part. I definitely agree. I think doing research makes you a better position overall.
Yeah. And it makes you enjoy your job more, I think, if I'm
It's a
honest.
lot more interesting. Exactly.
Yeah.
Uh, yeah.
Yes, Dr. Me, thank you. This is really great and exciting, and I especially loved the orbital star study. It really clicked, and I think with that design, you really cracked the code for what actually happens in clinical practice, because you're inflating the balloon there, and the patient is having symptoms, and you're actually happy because you know that you're doing something for this patient. Because if he's having this symptom while you're ballooning, most likely whenever you're going to put a stent, the rest is going to be patent. He's going to be uh, less symptomatic. So that was really exciting for me. And you actually answered one of my questions, which was utilizing the same technique with the balloon occlusion for understanding in multivessel disease, the vessel that might be the culprit, because that's oftentimes the question that we have. And going back into the two pathways that you showed, and I think we have answered with the Orbita and Orbita 2 studies a few questions, but I think, and I wanted to know your take on this, if we have an answer yet to the question of a patient that presents with angina, and the patient is naive to therapy, and now apparently we can have one or two pathways. So medical therapy, and then if anything, we can proceed with PCI or PCI first. And I was wondering, I was just thinking on the top of my head, and I was just curious, what do you think about a trial design where we had that kind of a double randomization? So a naive patient that's not on therapy, we randomize both. So we have the patient going through some placebo pills and a placebo procedure, and one arm just get the pills and one arm just gets the PCI. And we see and compare the outcomes in these two groups of patients.
Yeah, so you've basically designed somewhat Orbiter 3, which is actually already, yeah. So that's exactly what we're doing. I mean, it's not quite exactly what you said, but it's pretty much. So the next step for me, and I mean, maybe someone's going to beat us to it, but is that head to head, right? Well, okay, so you've got two pathways. Are they identical, or actually is there something some different about them? You might believe, I don't know, right, that you might be more likely to be rendered totally free from angina from one pathway versus the other. You might believe now, with some of the predictors that we've got, that one pathway will be better for some patients and the other will be better for others. I don't know, right? But that's exactly where I think we have to go next. The other place that, I mean, I'll give you kind of insight into is that I wonder if the same patient that gets better with their beta blocker or amlodipine would get better with their PCI, right? And the person that doesn't get better with their anti-anginal medication has non-cardiac chest pain or whatever they might have and doesn't get better with their PCI. So that's the other bit about clinical practice. These two things might work in the same way. And the patients who have residual symptoms, regardless of which treatment pathway you've taken, maybe they've not got cardiac pain, right? Or to Azim's point, maybe they have something else, microvascular disease, whatever it is, but it's something else.
Thank you.
Taylor? Are you there?
Yeah, I just had two questions about the coronary sinus reducer. The first being, when is the optimal timing to implement these with patients? And then second, I'm just mechanistically, I have a hard time understanding how exactly it works. I know you demonstrated that it improves epicardial, the endocardial blood flow, but how does that actually happen with the reducer? Like how does it increase the pressure difference between endocardial or epicardial versus endocardial?
Yeah, so I mean, these were exactly the questions we asked when we did it. I'm going to admit that I didn't think that it was going to work, and we've actually published recently a whole kind of a questionnaire series that we did on, whether how we interpret data and how our interpretation is influenced by whether or not we understand the mechanism of action. When we think something works, we don't care to do much, right? In terms of analysis, we just think it works, right? Has anyone ever sat there and thought about how opening the aortic valve might mechanistically make a difference to someone's heart? Yes, of course, we've got echo data and all the rest of it, but fundamentally, where we think something works, a pacemaker for complete heart block, we're happy to institute it. The reducer just does not seem to have an intuitive mechanism of action, but what's proposed is that there is essentially a backflow. Once you have a reduction in flow within the venous system, you have a back pressure that then influences redistribution of flow in the myocardium. Now, actually, much of the data comes from initial surgical ligation, so the Beck's procedure, animal experiments showing that this might happen. But fundamentally, what hadn't really happened before our data was a randomized, double-blind trial looking at endpoints. The problem with ischemic endpoints in the unblinded, uncontrolled data is that, of course, there's a variability in them and you can't tell what's the true treatment effect. I think the data that's going to be most important in terms of convincing me about how this works is whether in our patients, and this is data that we're going to be analysing and coming up with next, is whether if you see redistribution of flow, you also see symptom change. And if you can predict symptom change, and that's more dramatic in those patients who have redistribution of flow, then, I'm starting to be convinced exactly about how this works. But fundamentally, there's obviously much more that we kind of need to learn. To speak to the device itself, I went from being a total skeptic to being someone who's now implanting it clinically. I'm quite selective about the patients I'm doing it in, but I do think there's a role for it actually, and I think that role is still to be evaluated.
So can I ask a couple of questions about reduce? I've been waiting for someone to bring it up.
Yeah.
So the one is in Orbiter Cosmic, what was the non-responder rate in the treated group?
Yeah, we haven't looked at that yet.
Okay.
So that data I can't give you. We know that, there is, the series are different, right? Some people say a third of patients don't respond. Some say many more patients don't respond. And we haven't yet looked at the predictors of response, as I said.
Okay.
So that's all data that's coming. One of the things that is important to know that we also did is in the patients that we could do it in, we also performed a very comprehensive physiological assessment, including absolute coronary blood flow. But the problem with our patients is that they had very severe coronary artery disease.
Right.
So the only patients we could do it in was patients in which we could pass a wire.
Sure.
And so it's a quite selective population, but
Right.
that data might inform, what we do next.
Yeah. And then the other question.
And we did also, and one more thing, we also measured wedge pressure across the coronary sinus.
Across the coronary sinus.
Yeah,
great.
so some people have spoken to that.
Yeah.
So some people have spoken to that being a predictor, and so we've done that placebo-controlled in all the patients. So we'll have that data too.
Okay. So the one thing that surprised me, and I love your thoughts, when I saw the outcome data was that some patients were already felt a benefit at 1 day. Okay, and this was blind. Because the traditional thinking with a coronary sinus reducer was that the effects take a little while to happen, even though you are causing a stenosis, there will be laminar flow, but it's more when you actually endothelialize the device that you truly have greater stenosis. And so when I look at the data out there, particularly the single arm, retrospective data, sometimes you can see it takes 30 days. Or longer for there to be an effect, sometimes shorter. I was surprised by the 1 day. Any thoughts?
Yeah. So I don't know. It's hard to tell whether that's the one patient who has a massive placebo component, at the point at which. But what I would say is that, again, this is all stuff we're looking at. So there is discussions about if you implant across a valve and then immediately cause some kind of reduction in flow. There are discussions about whether you implant more distal or more proximal. I suspect we will be totally underpowered to really understand that stuff. I'm going to be honest. But all of that is stuff we're looking at. Actually, we're looking at all of the anatomies and trying to just understand. And again, to your point, with the MRI data, we'll be able to understand, because are these people who had a massive response in terms of redistribution of flow, albeit that's at a 6-month endpoint, but maybe, I don't know.
Okay, perfect.
Yeah.
We're going to give you the last couple of questions from the team. Wakas, did you have a question? I saw your camera on.
Yes. Hi. Thank you very much for this excellent talk. I have a question about the Orbita app, and then you were saying that angina scoring system. We know like female patients tend to have like atypical symptoms. Did you see any difference in the scoring between the male and female patients in your clinical trial patient?
Yeah, great question. So actually we didn't. So in fact, akin to there's data that came out of Scotland a couple of years ago, similarly, female patients were as likely to have typical angina in our cohort. Now, of course, they have severe coronary artery disease, etc. They were as likely to have typical angina as male. And we saw no difference in terms of the sex distribution in terms of atypical symptoms. But if you're female or male, whichever way around, with atypical symptoms, your PCI didn't really work. So yeah, we didn't see that. Now, you might say maybe we were underpowered for it or any of that, but we didn't see that difference.
Okay. Thank you.
And to follow on to that, actually, just because I always get asked that, the same with diabetics, actually. We didn't see any distribution. No, yeah.
Okay, those are, I guess, some of the areas we have misconceptions about. Antonella?
Hi, hello. Yeah, thank you for the great lecture. I was wondering actually if you have seen some difference in the Orbita first and second trial, if you have seen any difference about symptom management between patients who have already an history of prior PCI compared to people who was the first time you detected the CAD.
Yeah. No, that's a great question. So actually, we've never analysed that, because the proportions of patients with previous PCI in both of our cohorts were very, very small. Many of these patients had de novo disease, basically. So we've never analysed it, because I kind of thought we would be underpowered, and also because it wouldn't, the randomisation is kind of, we're now looking at a subset of patients that's not been randomised. I don't know. I don't know if restenotic lesions or, recurrent lesions in the same patient who's had PCI before are any different.
Thanks.
Perfect. Thank you. So I think we're going to let you go there, Rasha. I wanted to thank the faculty and fellows for the great questions and the great discussion. And congratulations or good luck to the fellows interviewing here at Monty today. And thank you to everybody for joining, but especially thank you to Rasha. Because as always, your talks are phenomenal. You explain concepts so well, and we really enjoy learning from you. And we can't wait for Orbiter 10. So just keep going. It's incredible what you're doing.
Pierre will join me with Orbiter 3.
Absolutely.
Absolutely.
It's great seeing you, Rasha. See you in a few weeks at TCT. Okay.
Thank you guys so much for having me. Good luck to the fellows.
Okay.
See you soon.
Thanks so much. See you soon. Bye-bye now.